speaker for Oricam brand. Ma'am is also running academy called Dr. Qurrath's Academy of Endodontia. Now I will introduce to Dr. Iftekhar sir. Sir has graduated in Bachelor of Dental Surgeon in year 2000 from SGM Dental College, Chitradurga, and MDS in Conservative Dentistry and Endodontics in a year 2004 from Bapuji Dental College, Davangere. Sir has total 17 years of teaching academy experience, and he is also a member of Aesthetic and Cosmetic Dentistry. Presently, sir is working as a professor for the Department of Conservative Dentistry and Endodontics in Sri Rajiv Gandhi Dental College and Hospital, Bangalore. Sir has various publications in national and state level journals. On March 2010, sir has presented the topic basics in rotary endodontics in Shifa Hospital, Bangalore. Now I would request to Dr. Qurrath ma'am to take over the session. Yes, ma'am.
Thank you so much for such a warm welcome and such a nice introduction about me. Thank you so much, Doctor. So, like Doctor said, my today's topic is on Blunderbuss Canal. So, coming to a few of the introduction about this topic. So, talking about the anatomy of apical foramen. So, if you actually see the anatomy of apical foramen, it varies with age. The apical foramen anatomy is very different as a young individual compared to a person, aging. And also, this anatomical changes happen once the tooth erupts in the oral cavity. As we know, when a tooth erupts in an oral cavity, for the complete closure of your root to happen, it takes minimum 3 years. So open apex means that your root has not completely formed. Your root end is not closed. So this leads to a lot of challenges for a clinician, to carry out the endodontic procedure, right from your, endodontic procedure till everything, even the restorability, everything matters in this. So when we talk about the, what are the challenges, is because of few of the reasons, like you have your canals are open, your dentinal walls are very thin, the remaining dentin thickness is extremely thin, there are higher chances of fracture which can occur during the procedure even after your endodontic therapy has been carried out, since the apex is not closed. So what happens is, as a clinician, when you're trying to restore it, whether you're doing a root canal therapy with different techniques, there are higher chances that you can extrude, your filling material, your irrigant, beyond the apex. So this can lead to a lot of complications. So knowing what is an open apex, how to, treat such kind of cases is utmost important. So coming to the success of endodontic therapy, we know it very well. There are two factors which plays a very important role. The first most important factor being your coronal seal. So your coronal seal plays an important factor to prevent the micro leakage. Okay. And then you have your apical seal. So when I say open apex, if there is no proper apical seal towards your 3 to 5 millimeter of your area, that can lead to root canal failure. Irrespective of how well you have done, it can, lead to endodontic failure. So coming to the classification of your open apex, there are two classifications. One is called as your blunderbuss canal, and the second is called as your non-blunderbuss canal. So if you see in this picture, you can see that the apical area is quite wide. If you see the canals, they are quite divergent. They are very divergent. And the remaining dentin thickness is quite thin. And also, if you see the shape, it is called as a funnel shaped. And if you see the apical foramina width, it is much wider compared to your coronal aspect of your tooth structure. Again, if you talk about the non-blunderbuss, if you can see it in this, you can see the canal is quite cylindrical and the canal walls are quite converging. and converging. And again, if you compare it with this, the remaining dentine thickness is quite okay, but still the remaining dentine thickness is less. That can lead to failure. So your blunderbuss canal is basically derived from a Dutch word which means dunderbuss, which basically means a thunder gun. So if you see here, this is a 18th century weapon which is called as a short wide barrel. So what are the different problems which are associated with this non-vital immature apex? As we know, your apex are quite wide. Your canal walls can be convergent, divergent, parallel, and they are very thin dentinal walls. Like I said, when I started, they are more susceptible to fracture during the treatment and even after the treatment. And on a long-standing case, they can be presence of a huge periapical lesion. So this periapical lesion may or may not be associated with root resorption. So the short roots plays a lot of problems when you have to restore, a tooth which has roots which are very short, when there is no adequate crown to root ratio, that can lead to a lot of complication, fracture, mobility, and so on. And then fracture of the crown. Now, when there is a fracture of crown, especially in your anterior teeth, that leads to, compromising the aesthetics. And you have to initiate an endodontic treatment so that you can rehabilitate both your crown as well as your root structure of your tooth. And long-standing cases, and like I'm sure, as general practitioners in our day-to-day practice, we'll see a lot of cases, especially your front teeth, which are, frequently discolored. So if you ask the patient will, give a chief history of trauma leading to discoloration as well. So there are different stages in root development. This is stages given by Sivak. So this is the radiographic staging. If you see here, you can see the canal walls are very divergent and your apical foramina is again very wide. And if you see the root length, it is not even reached half of the actual root length in the first radiographic staging. In the second radiographic staging, again, your canal walls are very divergent. The apical foramina is quite wide. And again, the length of the root, if you see, it is again less than half of your actual root length. Then again, if you see the third staging, again, the canal walls are quite wide. They are very divergent. Your apical foramina is again not formed and it's quite wide, and it is not even reached 2/3 of the actual root length. If you see the D staging, in this staging, again, your canal walls are quite divergent. Your apical foramina is again open. It's quite wide. But if you see the root length, it's almost reached, the root length. The actual root length or the final root length. Again, if you see the E staging in this, again, your root length is completely formed. It's like almost like your root is completely formed to its actual root length. So this is your radiographic staging. So again, if you see in this, there is no apex which is formed. That basically results in incomplete root formation leading to open apex or your blunderbuss canals. If you see again the staging here, in stage 1, you will see only 1/4 of your root is formed with a huge open apex or your blunderbuss canals. In your staging 2, again, half of your root is formed, again with your open apex or your blunderbuss apex. Again, if you see the third stage here, only the 3/4 of your root formation has happened. Again, the canal is blunderbuss. If you see here, almost your entire root length is formed. But again, if you see here, the canal, your opening, your apical opening is still open apex. And again, here there is complete root development. If you see here, if you compare the 4th stage and the 5th stage, here the apex is open, but this is somewhat partially closed. And here, if you see, there is complete root development with the complete closed apex. So these are the staging, which is basically given by Sivak, one of the most common and famous staging of your root development. So talking about what are the common causes for this root apex formation to not be there? What are the reasons for this incomplete root apex? So if you see, one of the common cause is trauma. As a young individual, trauma to your anterior teeth is very common. One of the reasons why it is common is because of the positioning of the teeth in the jaw. So this injuries or the trauma can lead to pulp exposure. This is one common reason. The second common reason is caries. If they are deep dental caries, again, that will involve your pulp tissue leading to, pulpal exposure. Then again, you have, say, orthodontic treatment. When there is excessive force, mechanical force, which is applied, that can lead to resorption of the root. So that can, if a patient is young, if too much, I don't know much about it, but the basic reason, leading to resorption is this. Again, the apex is not completely formed, and then again it leads to open apex or the blunderbuss canals. Then you have your root end recession or your periapical surgery can also lead sometimes to open apex if it is not done properly. Then you have proper instrumentation of your canal. So what happens is when you try to go beyond the apex or your minor constriction, again, that again can lead to your open apex or your blunderbuss canals. So coming to the management, how do you manage such kind of cases? So one of the basic thing which we need to keep in mind is epexogenesis. Now, what is this epexogenesis? Epexogenesis basically means removal of the inflamed portion of your pulp tissue. So what are you trying to do by this is you're trying to maintain, utmostly to maintain the vascularity of your pulp tissue. The first aim should be, whenever you see a case where there is an open apex, try, especially in your young kids, commonly seen in your young kids. So you need to make sure that the apex is closed. By how? By maintaining the vascularity of your pulp tissue. Now, say there is a normal day-to-day case in which there is a mechanical exposure of your pulp tissue. So you do not have to directly jump into going ahead with your root canal therapy. You have to try to make sure you maintain the vitality of your pulp by carrying out, procedure like epexogenesis, where you where you try to remove only the inflamed part of your pulp tissue. Followed by that, what you can do is you can go ahead with the placement of your calcium hydroxide, and recent advancements like your MTA, your biodentine can be placed onto your remaining healthy pulp tissue. So there are a lot of studies which have been done, which shows that if there is any mechanical exposure of the pulp tissue, if you leave it untreated for more than 168 hours, what it can do is it can lead to necrosis of your coronal portion of your pulp, limited to 2 to 3 millimeters. So you have to make sure whenever there is a mechanical exposure, you try to maintain the vitality by doing this procedure. So what are the most important goals of your epexogenesis? What are you trying to do? Why you're trying to do this? Like I said, you need to maintain the vascularity of your pulp tissue by sustaining a viable Hertwig's epithelial root sheath so that there is continued development of your root so that you achieve the proper crown to root ratio. Like I said, you have to maintain the pulp vitality. Then you have to promote your root to completely close. Then you have to make sure a dentinal bridge is formed at the site of your pulpotomy. So these are the things you have to aim at. Now, this is the first case report. If you see here, if you see the clinical evaluation of this radiograph, you can see deep dental caries, which is involving your enamel, dentine, and pulp tissue. So this canal is quite wide. It is divergent. The apex is not completely formed. So the patient's chief complaint was pain. There was presence of pain for 3 to 4 days. And on clinical evaluation, there was TOP positive. And on radiographic examination, there was deep dentinal caries, which involves all the 3 layers of the tooth. So what I did is I started off giving the local anesthesia. Followed by that, isolation is very important in endodontics. Please carry out isolation with help of your rubber dam. Followed by that, working length was determined. So in cases of your open apex, how do you determine the working length? The working length has to be determined with the radiographic technique. If you see a lot of studies in the literature, there are a lot of studies wherein they have said that working length determination is more appropriate with the help of your radiographic technique, because in your open apex, there is no minor constriction which is formed. Your apical area has not been formed. So with the help, as we know, the electronic apex locator, basically determines your minor constriction. So it is not possible to determine your minor constriction in your open apex or your blunderbuss canals. So the appropriate technique to determine your working length is with the help of your radiograph. So you can use either your K files or your H files. So after determining the working length, next step is your instrumentation or your biomechanical preparation. So generally in your open apex cases, if you see the literature and also according to the American Association of Endodontics, you cannot do instrumentation. There is no instrumentation. So instrumentation cannot be carried out. Now, if there is no instrumentation done, now how are you going to remove all the microorganisms from the infected root canal? So the most important, or the biofilms which are present. So what you need to take care or aim at is a proper irrigation. Irrigation is very important in such kind of cases. So the sequence of your irrigation plays a very important role that will further determine the success of your root canal therapy or your endodontic therapy which has been done. So talking about your irrigation, the first irrigant which you can place inside the canal is your sodium hypochlorite, followed by that your saline, again your sodium hypochlorite, followed by that your saline, and then again your EDTA. EDTA, there are many case reports which say you can use 17% EDTA as well, your 2% chlorhexidine irrigant, and then again followed by that you have to use a sodium hypochlorite, again saline, and saline would be the final rinse. Once you're in this case, I particularly had done a single sitting, single sitting endodontic therapy. So after your irrigation is done, what I did is I used the MTA cement. MTA cement is basically in the form of powder and liquid. I mixed it. Again, you can use MTA carrier or your amalgam carriers. If you do not have MTA carriers, as a substitute, you can also use your amalgam carriers to carry your MTA into the canal. So what you need to do is, for your apical plug with MTA, so 5 millimeters, your 5 millimeters of your apex has to be filled with MTA. So what you do is you mix your powder and liquid of your MTA and carry it towards your canal orifice, and then place it. And then another set of instrument which has to be there for your placement of MTA is your pluggers, your hand pluggers. You get a GDC kit, you get different brands of your hand pluggers of varying diameters depending upon the canal size. So you can have that. It's very, very, very useful. So after that, what you do is you use 1 minute. Yeah. So what you do is you take your amalgam carrier or your MTA carrier, place it near the canal orifice. After that, take a condenser and start condensing your MTA towards your apical 5 millimeters. So what you can do is you can do it in increments. You can take 1 millimeter, 2 millimeter, 3 millimeter. You can take the increments and condense it with the hand pluggers. For this procedure to be compactly condensed, you have to take subsequent radiographs. Radiograph needs to be taken to make sure there is proper condensing of your MTA towards your apical 5 millimeters. And once your apical 5 millimeters has been placed with MTA, what you need to do is the remaining canal needs to be backfilled. So how you go ahead with the backfill procedure? You need to use your sealer in the remaining part of your canal. Followed by that, you have to use your thermoplasticized Gattaparka technique to backfill your tooth. So if you can see in this picture, you can see your apical 5 millimeters have been downpacked with your MTA, and the remaining area is backfilled with your obturating material. Followed by that, a 2 millimeter thickness of GIC needs to be placed here, and then your composite. The remaining core needs to be done with the composite to make sure there is proper seal. Like I said, your coronal seal, here there is a double seal, so that there is no micro leakage which occurs resulting in your root canal failure. So this is your case 1. Now coming to your case report 2. So this was more challenging compared to the first case. The reason why being because if you see the radiographic examination, you can see a separated H file. You can also see the GP extruding beyond the apex, and there is periapical lesion as well. So in such kind of cases, you need to be very careful while you're trying to retrieve your gataparka, trying to make sure there is no break here, trying to retrieve it as a whole so that there is no extrusion or breakage of your GP at this point. So first what I did is I removed this gataparka as well as the separated instrument from the canal. If you see here, it's completely clean, making sure that there is no sealer which is adhering to your canal wall. I used the edge file to determine the working length. As you can see here, the apex is quite wide. So I determined the working length with the help of a radiographic technique. This I had carried out in 2 sittings. This was not done in a single sitting. I had done it in a 2 sitting. So what I did is, as like I said, no instrumentation can be done in most of your open apex cases. So irrigation again plays the most important role to remove. As you can see, there is already a periapical lesion. If you see, the root canal which has been done previously has been failed. So if you see the amount of the bacteria, it's going to be 2 to 3 times more when compared to that, where the initial root canal therapy was carried out. So here the sole thing which completely relies is on your irrigation. So again, irrigation is very, very important in endodontics. So again, I carried out with your sodium hypochlorite saline, again sodium hypochlorite saline, then again EDTA, again saline, sodium hypochlorite, and then final rinse has to be there with your saline. And then what I did in this case is I placed a triple antibiotic paste. Okay, I had placed inside the canal for almost 7 days. So whatever the chief complaint the patient gives, whether it's a history of pain, whether it's a history of sinus opening, foul odor, patient complains of, pus discharge, anything, all the signs and symptoms should completely relieve on the second sitting. Whether it's TOP positive, whether it's pain, whether it's sinus opening, everything has to relieve in the subsequent appointment. Say now I carried this procedure in 2 sittings. So the second sitting, I tried to make sure all the clinical signs and symptoms is completely relieved. After relieving the clinical signs and symptom of the patient is only then you go ahead with this apical plug with your MTA. If the symptoms are still persistent, the patient still complains of pain, if you feel that the sinus is not completely healed, please again go ahead with your irrigation protocol, again changing of your triple antibiotic paste. Do not jump off, finishing it with your endodontic procedure. Do not, until and unless your complete signs and symptoms have relieved. So the second sitting, what I did is again removing plays a very it's not just placement of triple antibiotic paste, the removal again plays a important challenge. So what you need to do is, when you're using your irrigation, whether you're using your intracanal dressing from the canal, you have to make sure you use an ultrasonic device. Okay, so there are a lot of devices in the market. So what I used here was Densplice endoactivator. So I used the endoactivator and agitated the sodium hypochlorite with the endoactivator so that I could remove all the triple antibiotic paste from the canal. And then again, the irrigation protocol was followed. After the irrigation protocol was followed, you have to dry the canal with your paper points. And then again, the same procedure, what I did in case 1, I used the MTA powder liquid and then I condensed it, apical 5 millimeters. And then you can see the backfill, what I have done here. So this is the summary of this case. You can see the apical 5 millimeters filled, followed by the backfill with your thermoplasticized gataparka technique. Again, this is a case report 3. Again, if you see here, there is a periapical lesion. And if you see, the GP has been extruded beyond the apex. This is the reason for the failure. And this root canal was done almost 10 years back. So again, the patient complains of pain. There is sinus opening. Patient says that there is foul odor from the oral cavity and there is, pus discharge which keeps coming and goes away. So again, all the symptoms, if you see it, if you correlate with the radiographic diagnostic, which says that the root canal therapy has been failed. So again, here the GP was completely removed from the canal. Working length was again determined with the help of the radiographic technique. Followed by that, the irrigation protocol was done. This root canal procedure was followed in the 2 sittings. It was not done in a single sitting. 2 sitting endodontic procedure was done. Triple antibiotic paste was placed for almost 14 days. Followed by that, the down pack was done with your MTA and then backfill with your thermoplasticized Gataparka technique. And then you can see the GIC which has been placed here, followed by that the composite. So what are the international guidelines? These are few guidelines from the International Association of Dental Traumatology for management of your traumatic dental injuries with open apex, immature open apex. So the endodontic management of your incompletely developed teeth in a fractured or a luxated teeth. So RCT should not initially be initiated until and unless there are any clinical or radiographic evidence of pulp necrosis or any periapical infection. Only then you have to go ahead with your root canal therapy. Otherwise, you need to do a proper follow-up. Say in an interval of 1 week, 2 weeks, 4 weeks, 6 weeks, follow-up needs to be done for the patient. If in the follow-up you have to take a periapical radiograph needs to be taken, occlusal radiograph needs to be taken as initial. And then you need to compare it whenever the patient comes, say after a week, again, 2nd week, 3rd week, 4th week, 6th week, you need to keep comparing the initial signs and symptoms of the patient. Say in the further signs and symptoms in the initial follow-up, if the patient says that there is any resorption, it is very rapid in children. If you feel that, radiographically, there is even a bit of resorption, please start off the root canal procedure in young kids. And again, this is the protocol for combined traumatic injuries, fractured followed by intrusion. There is higher risk of necrosis and infection. So root canal procedure needs to be carried out in such kind of injuries in a incompletely open apex. So coming to my conclusion, the practitioner should strive to achieve this root development through epexogenesis whenever it is possible, trying to make sure you maintain the vascularity of the pulp tissue. If at all the treatment fails, only then you have to initiate the epexification procedure. However, the most important factor is the debridement of your canal and making sure there is proper apical closure with the situable material to make sure there is no further failure. These aspects allow the body to reorganize and repair your periapical tissue. So if you see in my most of this, case reports, I have used apical barrier with MTA, which allow the treatment of the open apex in single sitting or 2 sitting, avoiding the risk of canal contamination or any radicular fracture, as well as optimizing the time of the endodontic treatment. So thank you. Thank you so much.
Thank you, Dr. Qurrath ma'am, for brilliantly you have explained all the points you have included. So now we'll move to question answer session.
If I may interfere, Dr. Sharif, can you stop screen sharing, please, and then we can get back to the discussions.
Sorry.
No, that's fine. Brilliant. Yep. Sorry about the interruption.
Yes, sir. So the first question is from Dr. Ali Mubarak sir, from Gausia ma'am. What are the challenges while anesthetizing the teeth with blunderbuss canals?
See, challenges would be like, say if there is a open apex, which is a long-standing case, which is necrosed, completely non-vital. If there is any periapical pathosis, or if there is a sinus opening, definitely there is a challenge. You cannot inject in that area. So, most of the cases, what you can do is you can initiate your access opening, since the tooth can be, completely non-vital. You do not have to, give infiltration or any block in such kind of cases, you can just start off with the access opening. And anything else doctor could add?
Yeah, see, as Dr. Qurrath mentioned, most of the cases are non-vital. So you generally don't need to anesthetize the tooth when you're doing the access opening and even completing the whole procedure as such.
True.
And otherwise, you can always give a block and do the procedure. It should not be a much problem.
Actually.
Okay. So the next question is, what is your perspective in MIH, molar incisor hypermineralization, afflicted teeth while involved pulpally?
See, again, molars,
Yes, sir.
What we need to aim is to maintain the vascularity of pulp tissue, trying to make sure there is continued root to crown development. So like, I exactly did not understand what they are trying to ask.
I think this
Can I
question from Dr.
Sir?
Ghosia basically for MIH is pedo related, or so she wanted to probably, but I think main thing in MIH is the hypomineralization.
Could we, sorry, Dr. Ahmed, could we ask Ms. Dr. Gausia to ask this question directly, please? So she'll be able to clarify what she's asking.
Yes, the thing is, MIH teeth, afflicted teeth are usually difficult to be anesthetized. And if they're pulpally involved, where the lesion is already involving the pulp, then how are we going to, address the anesthesia? Because that's what is the challenge right now, that it's difficult to anesthetize these teeth. And inevitably, these teeth are, with blunderbuss canals, because they're affected much early in the age of life. So that's when my question was. It was a continuation of the previous question.
Okay. Ma'am, you should only answer this.
Actually, I would like to ask Dr. Ghosia itself that why is anesthesia difficult in MIH cases?
I don't know.
I think we can take Dr. Amina in the panel as well, if she can, the senior pediatric dentist, if Madam can shed light. I mean, I always find MIH afflicted teeth quite challenging when anesthetizing. And that's when I see, like vice versa, the endodontist would be wanting, as it is, the children are uncooperative. So usually, we, at least in the practice which I do, we combine, pediatric and endodontics work when we're addressing the blunderbuss canal category afflicted patients. So management wise, I take care, and then the endodontist continues the treatment. So I would like to see what Madam said.
Good evening. I think it was a wonderful cases discussion, very short and very crisp, not very elaborated discussion, because we lose the track of it, which I like about this presentation. Congratulations, Dr. Qurrath. Yes, and Dr. Gausia, you have you brought a very I would say very less discussed or under discussed topic, that is MIH with blunderbuss canals, because usually we diagnose the cases, we come across these cases of MIH at a very early age, that is between 6 to 7 years of age, when the children, the permanent molars and the central incisors, they erupt, the parents, as a concerned parent, they visit a dentist, and we have to do, and they're more concerned about the aesthetics. Even if it is not endodontically involved, we have to do some aesthetic rehabilitation, and the teeth are a bit sensitive, and definitely the issue of anesthetizing these cases is a challenge for a periodontist also. What I do in my practice, I do infiltration technique, and I find that if I do it the procedure for a very shorter time, like if I have to do a restoration or do a kind of a crown, I have to do like a stainless steel crown or a PFM crown, I feel that anesthesia is effective. Regarding endo, I know it's a big challenge. I prefer to do the endo in multiple sittings, so that I give, because the children, they're really very apprehensive, and doing a long procedure with the sensitive cases, I prefer to do such cases in multiple sittings. Like in first sitting, I'll anesthetize and I'll just remove the coronal portion of the pulp and give a dress. The child is also the sitting, like in the subsequent visit, the child becomes more cooperative and allow me more time to probe into that case. But I feel that, that anesthesia managing the patient doing a long endodontic procedure becomes really difficult, and even the prognosis is very compromised. So really a big challenge to convince the parents also, because we need the compliance from the patient to visit us regularly to see that the progress of the treatment which we have done. But Dr. Gausia, we'll like to probe into this issue in a subsequent series of lecture. Somebody should come up with how we can manage the pain, like what should be the secret ingredient in that anesthesia that can help in the effective management of the anesthesia in such cases. Over to you,
now
Dr.
adding
Gausia.
on to this,
What
yes,
about
ma'am. Adding on to this, since we have so many endodontists here, I would want to know if Articaine can help in such cases. Yeah,
Yes.
I mean, what is
you
your
can.
experience basically, Dr. Iftekhar or Dr. Ijaj or Qurrath, if MIH you guys have encountered in your approach?
Sorry, can I just ask, what are your thoughts on regional analgesia? Why can't we gas the kids, and then give them local anesthesia, make them feel happy, and then anesthetize them? And I think that should sort the problem out. This is just my opinion. I'd request Dr. Sultana to provide her insight in this, please. Dr. Amina Sultana.
Dr. I'm Dr. Amina
regional,
Sultan.
Yeah, sorry, Dr. Amina Sultan. Yes.
I missed the question. Was I'm attending
See,
this
my my suggestion is regional analgesia, RA,
yes,
for kids. They will feel more relaxed, and then you could give them your blocks or infiltrations or whatever you want for the tooth, and then treat the tooth.
Not just a block. It's the procedure of endodontia, which I was
sorry to interrupt. Yes. As a periodontist, all feel that sometimes you have to come like we have to work beyond the textbook. What the textbook, something the situation is not ideal. Like it's very, sometimes it becomes, it may look very convenient talking that we can give infiltration, but if the child is uncooperative, the child is young, apprehensive, and we have parents also with us.
Yeah, that was my thing. Why don't we give regional and RA first, and then anesthetize the child?
Yes.
Because of their apprehension, wouldn't RA help them?
Yes, and there's not a single tooth involved. See, in MIH, all the 6 are involved. And sometimes the incisors are involved. There's not a single tooth involvement. The child has to come for the multiple sitting. And these days, it is an era of pharmacological management. Everybody thinks of, talking about anesthesia. People are not even bothered. They directly take the patient under sedation. So no offense to those people, but I feel like on the chair in a normal circumstances, anesthesia is an issue in MIH. I agree to what Dr. Gausia has brought up, this thing, like little under discussed topic. We should probe into this area more.
My question is, ma'am, is it like similar like treating a hot tooth?
Yes, and that is exactly what I was looking at, Dr. Qurrath, your perspective. If you have attended an MIH and you have compared a hot tooth and MIH afflicted tooth, that's exactly what I was looking at. If you have got an experience, or Dr. Iftekhar.
It is very tough.
Yes.
It is very tough.
Sometimes that tough when I'm treating an MIH afflicted tooth. That's what I feel. I mean, I don't know if they are the same. So I would like your perspective.
Even a hot tooth, like you said, it is very difficult, and it is very difficult, like especially in your lower anteriors where there are multiple nerve innervations. So your local anesthesia doesn't act that well, the normal lignocaine. So there are various techniques which are given to make sure, there is adequate anesthesia which has been given, like Articaine, but it takes a lot of time to have adequate anesthesia. One of the drawbacks with Articaine is that prolonged duration. I mean, it takes a lot of time to initiate the complete anesthesia. It takes time compared to your lignocaine. But in hot tooth, it is one of the best local anesthetics which is used, apart from the alternative intraligamentary techniques and everything. So Articaine is a better local anesthetic.
And what about this intraosseous anesthesia, the latest, the recent?
That also, like one of the recent advancements. So even in the hot tooth, they even go ahead with that, ma'am.
Okay.
I think so. This topic is still open for discussion and I mean anytime I guess if the endodontist can shed light of the blunderbuss canals managed in MIH afflicted, I would further appreciate if any webinar comes up. Inshallah. I think we can move to the next.
We need one webinar on this interdisciplinary pedo-endo, where you can discuss this MIH as a
For
subject.
periodontist, the pediatric endodontic is a dilemma. It's a dilemma to treat a patient because we get a patient with a single tooth endo case. We get cases where we have to do multiple treatment, multiple endodontic procedure, and sometimes when the child becomes uncooperative without anesthesia, then the managing in a normal situation becomes really very difficult, very challenging. So endo is really I would say, like, we are always dependent on endodontist to guide us to make it more easy and convenient to do it in a normal circumstances. And anesthesia is a big challenge.
And since we're talking about MIH, I think, can I ask something about MIH? I mean, the molar incisor hypermineralization, has it got to do anything with the nerve endings?
That was my actually question.
I mean, if you're talking in terms of the anesthesia not working to relieve the pain, I can understand the reason for hot tooth. But then in cases of MIH, I mean, does it really affect the nerve endings or the sensation or the perception of pain itself?
Correct, because in hot tooth, it is basically because of an inflamed pulp.
Inflamed pulp, yes.
Yeah.
Chronically
inflamed
MIH, pulp.
Yeah, but in MIH, what is it? Why does it give you difficulty?
I mean, the altered sensation of pain in itself in MIH, what is the reason for it?
Maybe the dentine hypersensitivity.
I mean, can we modulate the changes or change the technique in which we administer the LA, or like it has already been discussed, like Artican, which has a better penetratability compared to the lidocaine?
We can change the technique as well. We can use Artican compared to lignocaine, like you said, has better penetrability compared to lignocaine.
Yeah, like Madam said, I think this topic needs to be studied and I think discussed further. I think what I would do is can we request one of the members to actually take up this topic and then
Yes.
elaborate on this in the future webinars, please.
Yes, MIH is, I think, is we should come up with something on MIH, because I think we see amount of modded, like out of 40-50 cases which we see in a day, 1 or 2 cases we see of MIH daily in the area where I practice, in my NCR, National Capital Region. Like initially we were not taking care now, but now we are also concerned that this has to be taken up at a larger forum so that something good option comes up in dealing with such cases.
Thank you so much. Dr. Ijaj, please continue with the questions.
Okay. Thank you, Dr. Amina Sultan, ma'am. Now we'll move to the next question. What's percentage of NaOCl we use in Blunderbuss Canal treatment, and do you use in open apices?
Yes, you have to use sodium hypochlorite. So the recommended concentration according to American Association of Endodontics is 1 to 1.25%. You cannot use a 5.25% sodium hypochlorite. So now the question arises, when we use a 5.25% sodium hypochlorite, if you see the literature, it says that it is more effective in eradicating most of the microorganisms from your infected root canal system. But when you're using a lower concentration, the question is whether it will remove your microorganism. The answer would be yes. What you need to do is just increase the quantity or the amount of sodium hypochlorite which is delivered inside the canal. So again, like the chances of extrusion, further to make sure that you're not extruding your hypochlorite beyond the apex, you cannot use a normal gauge needle which you use for your anesthesia. You have to use a side vented needle where your end is closed and the vents are towards the side. the chances for the extrusion of your sodium hypochlorite again is reduced. So, preventing the extrusion of your hypochlorite beyond the apex. But yes, we have to use sodium hypochlorite.
But we have to use it 1 to 1.5.
1 to 1.25%.
1.5%. Okay. So, ma'am, one more question from Dr. Ali Mubarak, sir. Why TAP, triple antibiotic paste? Why not calcium hydroxide as an intra-appointment dressing?
See, calcium hydroxide, why not calcium hydroxide? See, I would say cases like resorption. Now we have to treat first the etiology. We cannot just jump doing a good root canal. What is the etiology for resorption? In cases like resorption, osteoclastic activity. In such kind of cases, I cannot just go ahead with triple antibiotic paste. So it is very case specific use of your intracanal dressing. So in such kind of cases, I have to use a calcium hydroxide dressing because I have to first aim at preventing my osteoclastic activity and, make sure that there is osteoblastic activity. So I have to use calcium hydroxide in such kind of cases. Triple antibiotic, why? When there are huge periapical lesions, my calcium hydroxide cannot aim at removing one of the most, isolated microorganism from your root canal, which is Efficalis. So if you see the literature, Efficalis has the maximum, one of the reasons for maximum root canal failures is Efficalis. And it's a known fact. You read any literature, it's clearly mentioned that calcium hydroxide is resistant to Efficalis. It cannot remove Efficalis. So, so this could also be one reason for using a triple antibiotic dressing. Again, it is case specific. It's not like every case you have to use your triple antibiotic dressing.
Okay, so ma'am, how we can remove this triple antibiotic paste or calcium hydroxide?
See, if you actually ask me, if you read any articles, in most of the articles, if you read, there is no instrument as such which can completely remove your triple antibiotic paste or any dressing from the root canal system. I can say, yeah, we have to aim at maximum trying to remove this dressing. If you actually see, the transverse section of your tooth after placement of your calcium hydroxide, your TAP, so, there are many, things which have been introduced to remove this. One such is your endoactivator, your various irrigation devices. Then you have various files which has been used. XP endo finisher is one of the recent advancement in your rotary files. So even this is aimed at removing your triple antibiotic paste. If you compare all, the technology, I would say that endoactivator is very, very good, efficient in removing your intracanal medicament, and your XP endo finisher is also comparable to removing your intracanal dressing, whether any dressing it is. And also, when you use your intracanal medicament, now say you're using your TAP or your calcium hydroxide cement, you're mixing with the oily based vehicle like your glycerine glycol, it is very tough to remove. When you use your saline, your local anesthesia, anything as your vehicle, it is very easy to remove it and it dissolves faster. But when you use a oily based vehicle, to remove your dressing becomes a challenge. So you have to make sure, that you use your irrigation devices to remove this dressing.
Yes, ma'am. So, ma'am, I want to ask one more question on TAP. And what is the drawback of this TAP?
As we know, it's discoloration. The reason why it is discolored is because we do not place it properly. One of the reason, it is very important when you place your triple antibiotic place, it has to be below your canal orifice, 1 to 2 millimeters below your canal orifice. One of the reasons, I'll tell you one of the reasons, even if you do a root canal therapy, now you have done a root canal therapy and you see that the tooth is getting discolored. Generally, we do not give crowns in your anterior teeth until, more than 2 surface of your tooth is involved, 2 to 3 surface of your tooth is involved. So when we see that the patient has come back with a discolored tooth, what is the reason for discoloration? Your GP, which has been placed in the pulp chamber. What is the reason for discoloration? It's you place anything in the pulp chamber, it will lead to discoloration. So again, we have to make sure that we play 1 to 2 millimeter below your canal orifice to make sure there is no discoloration. That is very important. Again, if you put it in the chamber, it's going to discolor.
So it is not minocycline.
No, minocycline definitely discolors. You have like advancements.
But we have to put it properly.
Yeah, placement is very important. You can go ahead with double antibiotic paste. You can go ahead with double antibiotic paste, or you can, replace your minocycline with your cefaclor, that is your second generation cephalosporins, to make sure, effectively it is acting. So there are various other alternatives, but trying to place is very important. First, we should aim at doing that.
So the safest alternative is calcium hydroxide.
Sorry, sir?
The safest alternative is calcium hydroxide.
100%, sir.
So TAP and DAP have their drawbacks.
Can we place Metapex also?
All
Yes,
these
sir.
things have a lot of drawbacks. Calcium hydroxide is the safest to use. If you go through the AAE guidelines and the ESC guidelines for treatment of immature permanent teeth with open apices, they recommend calcium hydroxide rather than using any of the antibiotic pastes. So, and the reason, I think Dr. Tamboli has just suggested the reasons for that as well, with regards to discoloration and stuff. But I think all of us could just do a little bit more research on the intra-appointment medications, and then we could, discuss it on our group. So the most safest modality is still calcium hydroxide, and it does the job. With regards to Iftekhar, it's a completely micro endo topic. We'll have to go into it more in detail as to why it can cause failures. As you mentioned in your talk, the most important thing is coronal seal. So every your Iftekhar source does not come from inside your body, but from the oral cavity. So having a sound coronal seal is what would prevent further leakage in and leading to failures. So I think we'll have to discuss this more when we.
The Iftekhar, one of the reason why I said calcium hydroxide is resistant to Iftekhar is because it has a mechanism in itself, the bacteria, it has a mechanism in itself that it will reduce the alkalinity of the calcium hydroxide. Basically, the calcium hydroxide acts better in high pH, which is around 11.5 to 12.5. But your Iftekhar is going to reduce the alkalinity of your calcium hydroxide itself. So where is the release of calcium and hydroxyl ions?
I agree with your point, Dr. Sharif. But when you're using a rubber dam, and you're using hypochlorite, you're actually making sure that the canal is sterile.
What about long-standing necrotic cases where there is a huge periapical region, where there is a resorption? In normal cases, I still go ahead with you, sir.
I would still use calcium hydroxide, the safest thing to use. And I would never use TAP or DAP for simple reason, as Dr. Tamboli pointed out. It's because of all that properties, discoloration. You did mention how the discoloration is because of how you use it. So you tell me how many of the skilled endodontists out there would actually know to place it 2 millimeters wherever you suggested. So it is actually technique sensitive, and it can be a lot of hassle when we are treating with TAP or DAP. I'd like Dr. Ahmed to add some light in this, please. Dr. Iftekhar.
Yeah. Excuse me. I totally agree with you, Ali. Actually, I've managed most of the cases with calcium hydroxide itself. I've never used TAP or DAP, and I've been, alhamdulillah, able to manage them. So, and you mentioned about coronal seal, yes. Also, the apical seal would definitely, help. Coming to what Qurrath is probably mentioning is, I probably would think of compromised patients who are probably diabetic, uncontrolled diabetes or something. But otherwise, I think I've always been able to manage with calcium hydroxide. And I think Dr. Amina was asking about Metapex. Metapex, as already Dr. Qurrath has mentioned, it is again oil-based. So she just didn't, Metapex is just a commercial name of calcium hydroxide along with iodoform.
Yes.
Which is nothing but Metapex.
I find it more convenient, like the easy to use, that is the reason. Sometimes calcium hydroxide is really very tedious job to place into the canal. Like that's the reason. Can Metapex, which is very easy to use, can we use Metapex instead of calcium hydroxide? Because I'm also a big fan of calcium hydroxide, but using calcium hydroxide per se really difficult for me.
Metapex is having calcium hydroxide in it. It's non-selective calcium hydroxide though. So here we do not try to use for epexification. We do not use that. We use as an intracanal medicament.
Okay.
I think Dr. Qurrath or Dr. Ali or Ijaj could throw some more light on it.
Sir, I want to ask Dr. Ali Mubarak, sir.
Yeah, go ahead.
Sir, how we can stop the osteoclastic activities by using calcium hydroxide?
Sorry, I didn't get that.
So how can we stop the, usually we use tap to stop the osteoclastic activities which are going into the canals because of the necrotic tissues. So how we can stop this with using calcium hydroxide?
I mean, let's go back to the basics. What is the reason for the resorption? What is the reason for the osteoclastic activity? It is a necrotized tissue. The tooth is yeah. So you are actually irrigating it. You're isolating it with rubber dam. You're irrigating to remove all the tissue, aren't you? You've made it clean. And so why do you not trust your clinical procedure, and you've isolated and cleaned it and sterilized that, and then use an alkaline-based solution to reduce the amount of bacteria, and then instead of relying on tap or dap? So the primary cause is the necrotic tissue, and you've got rid of it.
Okay.
Yeah. So I personally think it's logical reasoning. I'd rather go by logical reasoning and let the body heal, rather than stick some antibiotic inside the canal. And you've already mentioned the drawbacks of tap and dap.
Yes, sir.
Yeah.
Yes, sir.
So
okay.
That's my query. My suggestion. My thing is stick to basics.
Yes, sir.
And it'll heal. I'm pretty sure there are studies about it. If we go back and read about systematic reviews.
Actually, it is a traditional one. Okay, I think tap and dap. But when we were in college, we have used a lot of these tap and dap. But nowadays in clinic also we are not using.
I think there have been studies of late recently as well. They've said you can just stick with calcium hydroxide. It still does the job. And I think, the AAE and ESE, the bodies come out with guidelines based on all these studies. They don't just publish guidelines, without any reasoning. Okay. Even again, if you look at the trauma guidelines, and there is the pediatric I think there is a systematic review by Dugal and Torobnija 2017. I think you can go back and read these papers. They all suggest stick with a simple time-tested method. Yeah, but
I agree with that. I'm saying whatever you said, sir. It's very. We have to go a long way to replace calcium hydroxide. We can't
absolutely.
We can't just take calcium hydroxide from dentistry. So a lot is dependent on calcium hydroxide. Sir.
Absolutely, yeah.
Can I come inside the discussion, Dr. Ijaj?
Sorry, I can't.
Yeah, I'm Dr. Nadeem. Can I come into the discussion?
Yes, sir. Yes, sir. Sure, sir.
Yeah, these are a great webinar, Dr. Qurrath. Jazakallah khair for the wonderful talk. Assalamu alaikum to all the guys. I totally agree with Dr. Ali regarding the use of calcium hydroxide. The issue with every clinician, that would be me or anyone around, we obturate the tooth. So you never hurry up. So we need to give calcium hydroxide to, take its own pivotal role to act. It is 2 weeks, 3 weeks, wait for it. So the moment it is not acting, what we do is we switch to the other intracanal medicament as tap and dap. So we need to stick on to calcium hydroxide. If it is not, take it out, replace the calcium hydroxide, because the efficacy of calcium hydroxide, it starts deteriorating on the 3rd week and the 4th week. So you have to keep changing that. And one query I have to Dr. Qurrath and Dr. Ahmed, both of you can answer this. When do we choose the vehicle as your distilled water or glycerine? When do you want to choose for what case?
Like I said, we need to see the case when there is a huge periapical lesion. You want the release of your calcium and hydroxyl ions to happen at over a period of time. So then we go basically is for a oily based vehicle compared to your water based vehicle. So in such kind of cases, we try to choose, we want the release of your calcium and hydroxyl ions to be there for a longer period of time. So such kind of cases, I would go for a oily based vehicle.
Okay.
Most-
I have another query. Is it recommended that I use a water-based vehicle and change that every 2 weeks or 3 weeks? Will that give me the same result using oil-based and leaving it for a longer time, or will it change the
Definitely,
outcome of
sir.
it?
See, definitely, because if it is a water-based vehicle, solubility is higher, no, sir. It dissolves faster. So the release of the calcium and hydroxyl ions would be there for a limited period of time. So the mechanism of action would be there for a less period of time. So the result would be a little compromised. I would not say that there is a drastic change between using a water vehicle and oil vehicle. Drastic change, like no, we have to use a oily vehicle. It's not like that. Even if we read the case reports, it's almost comparable.
So the action of calcium hydroxide depends on the vehicle, the mode of vehicle it's been placed in. Is that what you're trying to say, Dr. Sharif?
Not really, sir.
Because you said, that's what you said, if you put calcium hydroxide with oily based, longer the hydroxyl ions stay.
Yes.
Dr. Ahmed, would you like to add something on that, please?
Yeah, I think in most of the cases, water-based calcium hydroxide should do the job. Again, oil-based, off lately, removal of it itself is a challenge. I think water-based calcium hydroxide should be good enough.
Yeah, I think we should just change the dressing every 3 weeks, because the reason is, as you said, oil-based is difficult to remove. And I think we're all moving towards, soluble or easily removable or water-soluble calcium hydroxide. And that's why they suggest you come back, call the patient back after 2 weeks or 3 weeks and replace the dressing. I mean, it's going to take you hardly about 20 minutes to replace the dressing. So the patient actually has a fresh dose of calcium hydroxide, which actually starts becoming potent against bacteria or changing the environment within the canals for the bacteria to thrive. So I think it's more suggestible or suitable to use water-based and change the dressing every 2-3 weeks in order to achieve good results. Yeah, so that, I think Dr. Nadim's point was to have patience with calcium hydroxide. I think that's what it is. And Dr. Tamboli, do you want to add something?
Thank you, Ali sir. Now the next question is from Dr. Nadeem Ahmed sir. Use of apex locator reading in open apex. Yes, sir.
No, we cannot use an apex locator in open apex because there is no minor constriction. If there is no minor constriction, we cannot get a reading. So open apex, when the apex is not completely formed, electronic apex locator would not give an accurate reading. So it's always better to go with the radiographic as well as the tactile technique.
Actually, in most of these cases, you have bone loss, and hence the apex locators generally don't work well. So as Dr. Qurrath has mentioned, your regular working length with a file would generally suffice.
Thank you, sir. Now we'll move to the next question from Dr. Ashiya Khalid. Some more light on treatment of blunderbuss canal with open apex and Ellis class 4.
Yeah. So coming to the treatment plan, there are various treatment plans. Like if you see in my cases, since it was easy for me to do, to be more honest. So that's when I went ahead with placement of MTA, apical plug. But there are numerous options for treatment of your blunderbuss canals. You can go epexification with calcium hydroxide as well. Like Dr. Nadeem said that patience is important. So you have to use calcium hydroxide as an intracanal dressing for say almost 2 to 21 months. you can use to make sure there is a calcific barrier which is formed, resulting in your root end to close. That is one such technique. Then MTA plug, you can use it with MTA or biodentine can be used again to make sure there is a proper apical seal. And then again, you can go ahead with something called as revascularization in endodontics. That also plays a very important role to make sure there is, root end closure to happen. So again, with PRP, inducing blood clot, PRF, there are a lot of things for your open apex cases.
You mentioned about revascularization for that. So can calcium hydroxide be used in revascularization cases?
See, we can use it, no, sir.
Because I was just
Like
reading,
what?
like for example, calcium hydroxide has this osteoclastic properties, and it affects the scap, which we generally want the stem cells to regenerate and all that. That is why in that it was mentioned that you need to be a little bit cautious about using calcium hydroxide in revascularization cases.
Okay.
Because revascularization itself is. Tell me.
So in such kind of cases, then what dressing we have to go ahead with? Like I have never come across that we cannot use calcium hydroxide. Then what
In
do you think?
revascularization cases?
Yeah.
Even I am not very, because revascularization is not still in the research level, because there are just few cases done. We can't generally, it's very, very technique sensitive, and I don't think so. Every clinician. Yes,
so may I come in, sir?
Please,
Sir,
please.
in revascularizations are in our setup, sir, we use the triple antibiotic phase, sir. We give 2 or 3 sittings of triple antibiotic phase till the time we are sure that there is no infection, the canals are totally sterile. Then we go ahead with the next step of inducing that the clot or whatever technique. But we use triple antibiotic phase in a revascularization case.
But do you use calcium hydroxide is the question.
Yes, sometimes it happens like there was a case that the triple, like one of the antibiotic was not available. So we consulted one of our endodontic colleague. He said that we can safely use calcium hydroxide also, but we should be sure that by inducing the second step, we should be sure that the entire calcium hydroxide has been removed. There should not be like any spec that can induce the osteoclastic activity. That was the only thing that we were warned about. Otherwise, we can use it. Nobody said it is contraindicated. We can use it, but in a very very cautiously, we should use calcium hydroxide. That we were advised about.
Yeah, I think this makes sense, Qurrath. Maybe we'll have to completely remove the calcium hydroxide before you go to the step 2 procedure of your revascularization procedure. I think that is what probably I overread. And there we generally call it maturation rather than epexification. Epexogenesis, we call it maturation. So
yeah, regeneration of the regeneration. Yes.
Okay. We'll move to the next question. Can we attempt a treatment of blunderbuss canal in a single sitting?
If the patient is not very much cooperative, say physically challenged patients, then might be you can. See, one of the reasons why single sitting endodontics has been done is to prevent cross-contamination. Like we aim at removing intracanal dressing. That's a very big challenge to completely remove it. So again, this is a big challenge. So depending on clinical signs and symptoms, like say if there is a sinus opening, it is not possible to do a single sitting endodontic procedure. You have to go for 2 sittings or 3 sittings depending on the clinical signs and symptoms of patient. So I would not say that every open apex case has to be done in a single sitting. No, if there is resorption, whether there is sinus opening, whether there is a huge lesion, patient is having pain, persistence of pain, we cannot do such kind of procedures in single sitting. It has to be done either in 2 sittings or 3 sittings, making sure all the symptoms are relieved.
Thank you, ma'am. The next question is from Dr. Gaushia, ma'am. Can discoloration of a tap be avoided by interchanging a non-tetracycline combination? There must be studies on different tap combinations to overcome few drawbacks.
Yeah, 100%. There are different combinations, like you have your double antibiotic paste where you try to completely remove the discoloring agent. So you can remove, like I said, you can also replace your minocycline or your tetracyclines again with your second generation cephalosporins like your cefaclor can also be used. So this will not cause any kind of discoloration.
Okay. Then the next question is from Dr. Nadeem Ahmed. Sir, role of collagen plug.
Collagen plug is very important, especially when you're using MTA. So if we actually see the literature, they see MTA is basically very high alkaline. So what happens is when it comes in contact with the bone, there can be necrosis of the bone tissue. If we see in most of the cases, it's happened with me also. It is surely happened with me also. There is a failure because of this. If you try to extrude your MTA beyond, though there are a lot of articles stating that it's biocompatible, it is not cytotoxic and all that. If you actually see many case report, it literally causes necrosis of your bone. So using collagen, making sure that area is stabilized, even in your perforation repairs, like your focal perforation repairs, keeping that area stabilized and then using your MTA to make sure it is inside the canal definitely does a lot of wonders in your open apex cases like your collagen.
Thank you. So you want to add? Yes, sir.
I just wanted to intervene. Yes.
Yes.
Let us take the anterior blunderbuss itself, Dr. Sharif. So imagine I take my collagen plug and I try to get it to the apex. Seeing through the naked eye would be very difficult. I do need magnification for that to see the apex to place the collagen plug. I think I would definitely agree with this, and I think most of the people would agree with this statement. So in case if I have pushed my collagen plug beyond the apex and default, which is not visible in any X-ray, so how do I conclude that my plug is sitting at the right spot, and how do I push my MTA to that particular spot?
See, sir, if there is a huge periapical lesion means the entire bone has been eaten up. So to diagnose it, clinically, like it's very tough. Like if we take a CBCT, there'll be a big hole in the bone, whether it's your maxilla or mandible, like a proper hole around your root tip. So again, that depends on the size of the lesion. How big is the size of the lesion? So definitely if we try to put it through the canal and push it, I'm sure it's going to go inside that defect, that bony defect. So that becomes very challenging. So we need to choose again, like such kind of cases, it's very tough to place the collagen membrane in such kind of cases because the membrane is going to go in the defect.
I'm not talking about the defect. Let us keep the defect aside. If I just happen to treat a blunderbuss and I need the collagen plug to go to the apex, and I need my MTA to start from the apex as my filling material, so how do I gauge if my collagen plug is sitting at the apex or not? That is my query.
So just try to condense it with a condenser. No? Just use a condenser and condense it, and then try to use a MTA, take an X-ray and see whether it's trying to go beyond. What we can do clinically is use a condenser and see till where exactly is your collagen plug. I think we can feel that when we're using the collagen plug, and then you can use MTA, condense it, take an X-ray and see if you're not extruding it beyond, then it means that area is, the collagen plug has been stabilized in that area. That's how I would interpret.
Okay, sorry. Let me just
how you manage in particular. That is how you feel with it. Your personal opinion. That is how you go about it.
I think Ali wanted to add something. Go ahead, Ali.
See, I think Nadeem's query here is with regards to regenerative endodontic procedures. Now, if you're placing a collagen plug, you should understand the reason behind it. It's just to initiate or hold the clot, which is what contains the stem cells. So technically, under a microscope, if you're treating a blunderbuss canal, you're able to see right up to the end. So when you push the collagen plug or you create the clot and then you want to place the collagen plug, the plug only acts like a medium to hold the clot. So significance of it, you have to do some simple mathematics by calculating your working length. And then, when you push the plug, you need to again use maybe your endodontic plugger to see how far it's gone by keeping your reference point as a working length. And then after that, you could place your MTA and seal it. This you need to do it in the second stage of your REPs. So if I think I have posted the ESE guidelines with regards to REPs on our group. So please check that for reference. I would suggest magnification as a must, especially when you're treating these open apical canals. I mean, in fact, for most endodontics, you do need magnification, which is, I think, a boon. So if you're doing it, then you need to work out some simple mathematical calculations. Plus, you should understand the reason for using the collagen plug. It's not something which will actually improve the prognosis of REPs, because most REPs, the outcome is unknown. All the scientific literature towards REPs do come across it. You can see some radiographic evidence of root maturization, but it may not look like a normal tooth. It may not be the same shape. They can vary. So it's just like I would say genetically cloning the sheep, which was done quite some time back. So it is quite a complex procedure because the outcome is not known. So the evidence towards REPs is still under the early stages, but hopefully in future we could regenerate proper apex, proper apical seal. We don't even know whether pathologically the tissue formed or the cementum formed has the same structure as a normal apical seal, because we're using the stem cells present at the apex or in the bone to initiate the growth factor and then initiate the maturogenesis. So it is quite complex. I think that's a different topic to be spoken on another day, but I think we'll stick with treatment here for blunderbuss canals in a clinical setup. I hope that clarifies the query, Dr. Nadeem.
Thanks a lot, Dr. Adi. Thank you, Dr. For nice answer. Thanks for that.
Yeah, I would just like to add here, see, as whether it is with collagen or without, when you're placing the MTA at the apex, as Ali had mentioned, as well as Qurrath mentioned. Ali mentioned about simple mathematics. Yes, you need to do that. And as Qurrath mentioned, once you place it, you take an X-ray. See, MTA sets late. That is one thing. So you take an X-ray and see whether it has gone beyond or not. In fact, we used to do that when we were placing initially, when we initial times, when our PG times, we didn't have the MTA carrier also. So we used to place it, use a plugger and then take an X-ray and see whether it has gone till the apex or it is short, and then accordingly plug more and all that. So what Dr. Qurrath mentioned was, I think, makes sense clinically. Take an X-ray, see, otherwise you can always remove it because it is not yet set. But on this, I just want to ask one question to Dr. Qurrath is, how about biodentine? Can you use biodentine instead of MTA? I know MTA is the standard material for blunderbuss canal, but can you use biodentine?
Yes, sir, we can surely use biodentine. In fact, if we actually see the advantages and properties, biodentine is way better than MTA. Because for a simple fact that it comes in a pre-capsulated form. So the powder liquid ratio is perfect, bang on, accurate. So if your powder liquid ratio is accurate, definitely all your properties are going to be tremendously good over MTA. So that is one thing. And like you said, sir, like MTA sets late. The initial set of the MTA itself is way late compared to your biodentine. Like biodentine, one drawback is that when you're using in such kind of cases, the initial set is 6 minutes for biodentine. And the complete set is like with 10 minutes, like 10 minutes, 10 to 11 minutes. Yeah, so that's only one drawback. Yeah, but apart from that, if you actually compare the properties, biodentine is way better than MTA.
Because it sets faster. So if you really do this technique sensitive, as you said, but if you're sure about it, just go ahead, do it, and even you can finish it in the same setting.
100%.
Yeah.
Okay. The next question is the efficacy of calcium hydroxide varies from patient to patient. Any particular reason for this? The efficacy of calcium hydroxide varies from patient to patient. Any particular reason for this?
I have no idea. I'm hearing this for the first time. Efficacy varies from patient to patient. I have no idea.
I mean, the question is in terms of the number of dressings of calcium hydroxide being applied. Is it same for all the patients or do they vary?
I can't understand. Doctor, can you
I
please
think
tell
I
me?
got your point. I'll just answer this, Qurrath. See, it actually is case specific. It's nothing to do with the patient as such. Depends on how much of infection is there, how much of osteoclastic activity is already there, which you need to neutralize it and form this osteocementum formation. Generally, when you're trying to do the regular traditional calcium hydroxide epexification procedure, that's why every 3 months, 6 months, you need to keep checking, doing that. It all is case specific. It's nothing to do with patient to patient. It is, I think, the condition of the tooth to the condition of in one patient to condition of the tooth in another patient. The same patient, in fact, you can have if two teeth are involved, they may not have the same amount of osteocementum formation. So I don't think so. There's anything to do with patient to patient. I think I have cleared your doubt.
Thank you very much, sir.
Yeah.
Okay. Anybody else want to ask something or add something? Hello.
I just want to say that it was a very good presentation, Qurrath.
Yeah.
Very good
Yeah.
The questions are over.
Very
Wonderful presentation. My last query, what is the prognosis of treating such cases? Long-term prognosis of treating such
Can't
cases.
say, ma'am.
So much of effort, like wonderful
say,
cases, but what is the prognosis? How you're going to convince the patient, how long? Because eventually the patient will go for the capping or the crowning also. The crown root ratio is already compromised. So what is the prognosis? Is it worth doing so much of effort, or we can shift or look anything beyond, like going for the regenerative endodontics or revascularization?
Ma'am, I would say regenerative endodontics, ma'am. Like, regenerative endodontics, like it's a good procedure. I feel, again, I cannot tell the prognosis, cannot judge the prognosis. It varies from, tooth to tooth. It varies in depending on the, status of the infection and everything. Everything matters. The prognosis is very tough to say. Like it varies in every tooth. There is a lesion, there is resorption. If the dentinal wall remaining thickness is very thin, the prognosis can surely be poor. So to give like, yeah, I have done this, it's going to stay, it is very tough to say, ma'am, in open apex cases.
I think case selection is very important in regenerative.
Yes.
Okay, thank you.
I think all the questions are over. So thank you all the members of GDP for organizing today's session. Thank you, Dr. Qurrath Sharif and Dr. Iftekhar Ahmed, sir, for the wonderful session. All the things, all the doubts you have cleared beautifully. And sir, we'll end the session. Dr. Gosia, ma'am.
Yeah, we'll end the session, but I just wanted to mention Ijaj Ahmed was my student, so
yes,
nice to see you as a moderator. Yeah.
I'm very happy to see Dr. Iftekhar sir. Iftekhar sir was my final year when I was in final year BDS. Sir was my examiner, so I'm very much happy to see you, sir.
Thank you. Worked for about 17 years. Yeah, nice.
Thank you.
Wonderful platform.
Dr.
I
Ahmed,
appreciate
Dr. Tamboli.
Dr. Gauzia to introduce me to this forum. Wonderful platform.
Before ending, I would like to add a few things. I would want to thank Dr. Gauzia, ma'am. Thank you so much, ma'am, for giving me this opportunity again on this group. I'm very glad. I feel very, very happy and very delighted that I got this opportunity to, speak and give my views and present my cases with such wonderful people around me who are way, way, way nicer. Thank you so much, ma'am. And thank you so much, Ali, sir, He has helped me out throughout the entire presentation. Like, he gave me so many things. He gave me articles. He gave me so many study material so that I can read about it. There were many things, sir, which I did not even know. And after reading your articles, I have learned so many things through that, sir. Thank you so much. And thank you, Dr. Tamboli, and thank you, Dr. Iftekhar Ahmed, sir. Thanks a lot. Thank you so much.
No, thank you, Dr. Sharif. It was a wonderful talk. We will continue the discussion in the group, and if any queries you could please put forward. Anybody has any doubts, we are more than happy to clear, and the discussion will continue. But thank you all. Jazakallah khair, and hope you have a wonderful